Thank you guys for tuning in. It has been a delight to have Pooja this month. She's done some really incredible things, and so I don't want to take up too much time talking. Um, I know we have Vera Reinstein on who's listening in. She is from Alliance Health, and we're also, Pooja, we are doing some additional work out in the field right now where a lot of what you have done with Dr. Burry at her pharmacy is stuff that we are trying to learn from in order to sort of develop more service models in different areas with nicotine replacement therapy, hormonal contraception, things like that. So what you have done is really something that resonates with other initiatives that we have going on. So they are tuning in to hear everything that you have put together. Of course, we have our fellow with us who's only with us for another day or two. I'm very sad as she moves on. And then Keiko and her staff are with us. And so, Keiko, I don't know if you want to introduce, I'm assuming your other pharmacist.
This is Christine. She's a soon-to-be pharmacist, but she's our intern from UNC who's also helping a little bit.
I met her at the very first of the month, right? Didn't I? Christine, didn't I meet you at the first of the month? Maybe not. I don't know.
I've been,
Sorry.
Hearing some of your conversations, and I've been liking the work you've been doing with Pooja.
Cool. Okay. Well, super. And then, of course, also have from Campbell University, William Branton. And Will, do you want to introduce yourself? Have you got audio? Or maybe you don't have audio.
Yeah, it doesn't seem like it's working.
Oh, he's saying, sorry, I don't have audio. Okay. All right. So anyway, so I'm gonna turn this over to Pooja so she can tell you all about the wonderful things she's been doing this month. And Pooja, if you want to share your screen, I'll just
Can you guys see my screen? Okay. Can you hear me well?
Yes.
Okay. So for the sake of time, I'm just going to start talking and then so we can get to questions at the end. But okay, good afternoon, you guys. My name is Pooja. I'm a current API student at Campbell, and today I'm going to walk you through the implementations, the outcomes, and the future direction of our opioid risk assessment and Naloxone eligibility toolkit at Carbo Family Pharmacy. So before I dive into the specifics, I wanted to give a quick overview of what we're going to be covering today. First, I'll start with some background and initial findings that led to our need for this project. From there, we're going to walk through how opioid risk screening was structured and implemented within the pharmacy setting. And then I'll break down the workflow algorithm step by step, followed by an explanation of the risk calculator tools that helped guide this clinical decision making. And then after that, we'll review the policies and procedures that were created to ensure consistency and sustainability. And finally, I'll wrap up with key findings and future directions for scaling and improving the service moving forward. So let's get started with some background and why this initiative really matters. So why is this work so critical, specifically here in North Carolina? In 2024, the estimated overdose rate in North Carolina was 29.7 per 100,000 residents, which translates to a projected of 3,213 lives lost due to overdose in just 1 year. Even by April this year, we'd already recorded over 1,000 deaths, and that's only a third of the year. And while that number reflects a 28% decrease from the year prior, it's important to recognize that this isn't a cause for complacency. It still represents thousands of preventable deaths. While we look at the emergency department visits on the right, the estimated rate for 2025 is 97 visits per 100,000 residents, or over 10,500 overdose-related ED visits projected for this year. Again, in the first quarter, there were more than just 2,600 visits recorded. And while that's a 15% improvement from the prior year, it still signals a major public health burden. And I think it's really important to remember that, hey, these aren't just numbers, they're opportunities missed for intervention. So let's zoom in a bit closer to home, Orange County, where Carrboro Family Pharmacy is located. In 2024, the estimated overdose rate here was 10 deaths per 100,000 residents, which equates to a projected 15 individuals lost to overdose in a single year. As of April, we had already seen 5 deaths, even in a county with one of the lowest overdose death rates in the state. The good news is this reflects a 56% decrease compared to the prior year. That's either meaningful progress or, on a sadder note, it can mean that a lot of the at-risk population has passed. So digging deeper into the local data, we look specifically at the role of illicit opioids in overdose deaths in Orange County. In 2024, 60% of all overdose deaths in the county were linked to illicit opioids, things like fentanyl, heroin, or counterfeit pills. That's a projected 9 out of the 15 total overdose deaths this year. And by April alone, we had already seen 3 confirmed deaths involving illicit opioids. This rate is considered among the highest in North Carolina, despite Orange County's overall low death rate. And it's down just slightly, a 7% drop from last year. So let's take a look at opioid prescribing trends in Orange County. In 2023, 8.6% of residents, or roughly 12,783 people, received a dispensed opioid prescription. This rate is actually one of the lowest in the state, which may reflect a more cautious prescribing habit by prescribers or alternative pain management. However, it's important to note that this figure still represents 1 in every 12 residents receiving opioids, and that's definitely not insignificant. And what's more is that this number has actually increased by 2% from the prior year. Lastly, I just want to highlight one more important data point. Buprenorphine prescribing in 2024, just 0.4% of residents in Orange County, about 605 people, received a prescription. This rate falls around the middle range compared to other counties, and there was a 6% increase from the prior year. So let's take a closer look at the opioid risk data from Carrboro Family Pharmacy over the last 6-month period. This is the real foundation of why we pursued this intervention. During this 6-month period, 127 unique patients were dispensed an opioid prescription. Of those, 13 patients, or roughly 10%, were on high-dose opioids, which immediately places them in a higher risk category for overdose. And while 10% might not seem alarmingly high in isolation, in a community-focused pharmacy, it's a significant number still. We also identified 4 patients who's been concurrently using opioids and benzodiazepines for over 30 consecutive days, which is a known high-risk combination, and 47 patients who are using 2 or more shorter-acting opioids, again for extended periods. And in addition, 34 patients had ongoing chronic use. But here's the most critical finding. Over this 6-month period, not a single naloxone was dispensed. So that's not just a missed opportunity, it's a silent gap in care. These patients were interacting and picking up opioids, but there was just no intervention in place already. So this underscores why the implementation and screening of our workflow model is so urgent and necessary. So in week 1, we focused on analysis, reviewing the current workflow, learning how to build care plans through Pioneer RX, drafting our screening process, and setting up Excel trackers for ORS screening. By week 2, we had focused on analysis, which was reviewing the current workflow, learning how to build care plans through Pioneer RX, drafting our screen process, and setting up Excel trackers. emergency plans and drafting physician notification forms and continuing that drafting that screening process. We had also launched our beta version of the workflow by week 2. By week 3, we had focused on implementation. We kept refining the problems in the workflow based on what we saw in testing. For example, embedding the provider notification form directly into that reports tab, which I'll talk about more in depth later, and finalized our policies and procedures. By week 4, we had wrapped with data collection and analyzing outcomes, finalizing our service model, and preparing this very presentation for to share the process and outcomes and recommendations. So now that we've covered the background and our implementation timeline, let's shift into one of the most critical components of this project, which was the opioid risk screening. This is where we start putting these proactive systems in place to identify patients who are at elevated risk of overdose, hopefully before an event occurs. And before we dive into the specifics, I want to take a moment to highlight the bigger picture, why this toolkit really matters and what kind of impact it's designed to have. The purpose of the opioid risk assessment and naloxone eligibility toolkit is to quickly identify patients who are at high risk for accidental opioid overdose to make sure that they're offered the naloxone right then and there at the point of care using North Carolina's standing order. What's powerful about the system is that it seamlessly integrates into Pioneer RX. So instead of juggling multiple platforms or calculators, everything from risk scoring to naloxone eligibility is automated, which cuts down on time for the pharmacy. From a public health standpoint, it's about saving lives, but also helping normalize naloxone through routine counseling. The more we talk about it and offer it consistently, the more stigma around it we can reduce. But let's also not ignore the business aspect. This toolkit would hopefully in the future open doors for medical billing by pharmacists. It also strengthens our argument for directing opioid settlement funds to pharmacies like ours and enhances our visibility and value as frontline healthcare providers. It also should hopefully improve patient engagement. Built-in prompts encourage stronger communication between the pharmacy, patient, and prescriber, and that makes that patient feel really valued. On the equity front, this toolkit helps us leverage free naloxone grant programs. So even with patients facing financial barriers, don't slip through the cracks. And Dr. Burry already had that in place pretty much. So it was very, very, very nice to see. And finally, it's adaptable. It can be tailored to fit any pharmacy's size, staffing model, or clinical focus. So whether you're a high volume pharmacy or a smaller pharmacy, it should work. So let me walk you through our structured opioid screening process really quick. It's built to ensure that, again, no high-risk patient really slips through the cracks. It begins with the overdose risk score, or the ORS, and this tool provides an automated estimate of the patient's likelihood of experiencing unintentional opioid overdose. Think of it as our yellow, green, red flag. It quickly gives us an idea of who may need further intervention. If a patient falls into that intermediate risk category, we move on to that tech RISORT step. Here, our pharmacy technicians use that RISORT screening tool to gather additional risk data. This step is crucial because it allows the trained staff to expand on the ORS findings without disturbing that workflow. This is our first layer of manual clinical evaluation, and it's only triggered when the risk isn't clearly low or high. Now, if that tech RISORT screen still leaves us in the gray area, meaning it's definitely still not high or low risk, we escalate to the final step, which is the RPH RISORT. This is where the pharmacist steps in. We take a deeper clinical dive to determine whether naloxone should be dispensed and what education and interventions are appropriate. In short, this layered approach, starting with that ORS, followed by that technician input, and ending with that pharmacist review, should give us a scalable, comprehensive, patient-centered way to identify opioid overdose in a community setting. So to implement the opioid risk screening effectively, we needed a strong foundation within our pharmacy software, and that meant fully utilizing Pioneer's care plan functionalities and customizing it to support the specific intervention. We started with the Pioneer University Care Plan workshop, which really helped us understand the structure and the tools available, such as care goals, care actions, and care statuses. From there, we built a custom care plan tailored specifically to Carborough Family Pharmacy, incorporating steps for screening and the eligibility and counseling. We then used categories to flag patients with opioid prescriptions. This allowed us to filter and identify those who qualified for that screening. One of the most powerful tools we used was RX triggers and RX edits. These created safety alerts and hard stops that notified the staff or even prevented dispensing when the risk factors were present to ensure that no one slipped through the cracks. Finally, we used the Incomplete Care Actions tab to track unfinished steps. This gave us a live queue of patients who still need to be followed up with, whether that was screening or whatever step in the process that really was. So before we move deeper into the workflow, it's important to understand the building blocks we worked with inside Pioneer RX. These 6 components is what made the project both functional and sustainable within the software. First, we have care plans, which serve as the overarching framework. These represent a patient's ongoing clinical journey and allow us to document goals and interventions over time. And then within the care plan, our care goals, this is a specific outcome that we want to achieve, like ensuring, for example, for us, it's ensuring naloxone was offered and counseled, and it was completed. And then under this care goal, there's care actions, which are the concrete steps the pharmacy takes to get us there, such as verifying risk and documenting refusal or filling that naloxone. And then care goal status lets us track that progress, whether a care goal is open or has been completed. This kind of helps us stay organized and know who's still needed for follow-up without having to click open every single tab. And then we're going to go into RX triggers and RX edits in just a second in the future slides. So here's how we applied these to specifically support our opioid risk screening and naloxone toolkit. Under care plans, we aligned everything around one central goal, and it created a consistent communication and documentation between the pharmacist, patient, and provider, and it was to ensure access to naloxone. And then our care goal was titled Opioid Risk Screening and Naloxone Eligibility Toolkit, which housed all the actions and tracking steps involved in that screening process, like we talked about before. Under that goal, these are the 4 specific care actions we built. Step 1 was initial RX review instruction. Step 2 was the ORS and RISORT assessment. Step 3 guided what to do for high-risk patients, specifically counseling and naloxone dispensing. And step 4 was that final sign-off and completing that goal. These are the care goal statuses you see on the left. It tracked patients' progress through the process. They range from initial review complete all the way to care goal signed off. We even created a status for pending RPH RISORT assessment, and you'll see how that's handy in a second, but this is when that further clinical evaluation was needed. And again, I'll get to that RX trigger and RX edit in just a second. So this was another key feature we used in Pioneer RX. It was a categories tool. This is what helped us automate that patient identification. We briefly went over this, but it allowed us to create those very, very specific data sets. For example, patient filling opioid agonists and partial agonists. This gave us the ability to analyze risk and track patients from those clinical angles. And more importantly, it supported that creation of that workflow alert. And once a patient met that certain category criteria, these alerts were triggered, which helped our pharmacy team quickly identify at-risk patients and resolve it in real time. And then these are our RX edits. These are hard stops used to notify the pharmacy staff when specific actions must be completed. In our case, if the opioid risk assessment hadn't been done, the system would generate a warning alerting the team to complete the task before that prescription could be filled. So basically, we built in an automated checkpoint. This edit prevented high-risk prescriptions from slipping through these cracks again. And now let's look at these RX triggers. We use to automatically assign our care plan to patients based on these prescriptions. So this is basically putting everything together. The RX trigger we built tied to that opioid risk assessment and toolkit. The RX trigger we created was titled Opioid Risk Assessment Needed. This was activated when that opioid entered that system and immediately ensured that that workflow was kicked off. And it worked not only in every fill, but every subsequent fill, which gave us multiple opportunities to intervene, especially because, a patient's risk status can change over time. And like I said, it all puts everything together. So it works seamlessly with that categories and the RX edits. And it kind of automated, and it was very, very crucial. So everyone that met that criteria, it attached that care plan, so we don't have to rely on memory or sticky notes. So now that we've covered the screening process that's embedded into Pioneer RX, I'm going to quickly move to the actual workflow algorithm, what the day-to-day process looks like when a patient fills that opioid prescription. This section is really all about how we took these tools, these care plans, categories, RX triggers, and edits, and translated them into a step-by-step system that technicians and pharmacists can actually follow. So to make this a bit more engaging, let's walk through the workflow using a fictional, but hopefully easily recognizable patient, Severus Snape. Let's say his provider prescribes oxycodone 10 milligrams every 6 hours for pain. Based on that alone, our system should immediately recognize this is a controlled substance and initiates that opioids risk screening process. So I'm going to walk you through both the high risk and the intermediate risk workflows to show how these decision points are built into the system. But first, let's start with that high risk workflow. So I am going to walk through this as if I'm a technician, and I'm just going to read it out loud with you guys. So this is that initial review instructions that should pop up as soon as it alerts them that they're at risk. So it says initial RX review instructions. Please highlight yes or no answers for documentation purposes. For each of these slides, really quickly, we're just going to ignore this please document all patients screened, because that was just for my documentation purposes, so I could have something to present to you whether this worked or it didn't work. So I'm going to skip to the first question, which was this patient provided with a naloxone prescription written by the provider? If they had, we would have just entered that naloxone prescription and kind of went to that care goal sign off tab and completed this through. But for our patient, they didn't. There's no prescription for naloxone, so we don't contact that provider. Naloxone can be entered under that standing order, so we're going to proceed to question 2. So our question 2 is, has naloxone been dispensed for that patient within the last year? For our patient, they didn't, so we said no, and then it asked us to complete this action and change status to 0, RX review complete, and then proceed to that second tab, which is tab 2, oral risk and virus assessment care action. So we're going to hit that complete, and then it pops up, and then we're going to click that initial RX review complete because that's what it's asking us to do. And this is what your screen would look like right after. And as it said in that previous question, where they want us to click that number 2 or risk and virus sort assessment because we still need to determine if they're at risk. And then this is what should pop up. If you notice, these are labeled. They were labeled 1 to 4, and we did that because as we were working through the workflow, Dr. Burry and I realized it was kind of hard to keep track of those tabs, and this was just an easy way for them to, quickly look at a step-by-step workflow. And this is there might be some steps you might skip here depending on what the answers to your questions are, but this is the full process. But okay, anyways, going back to our step 1, we're going to first access that patient's profile on that PMP lookup. So we're going to go ahead and click this link, and what should pop up is a login for text, and they have to log in separately. Only pharmacists have that PDMP lookup integrated into the system. So once they log in and they look up the patient, this should pop up on their screen. And what we're paying attention to is that overdose risk score right here and that average MME per day. So we got 480 and 6. So we're going to go ahead and note, it says please document. So we're going to go ahead and document that right here. And then it asks us to please highlight interpretation and complete the action associated with that interpretation. So over here, the ORS interpretation and actions. So we got that 480 score. So are we between 0 to 250? No. 251 to 449? No. We are above 450. So they are at high risk. So we want to dispense that naloxone. So we're going to go ahead and complete this action and then change the status to 6, high risk naloxone fill and counseling needed. And then we're going to go ahead and proceed to that tab 3, which is that high risk naloxone fill and counseling needed. So when we hit that complete, we would hit this, but before we get out of this tab, it also tells us to please enter a naloxone RX for the patient and put it on hold. So the reason why we decided to put it on hold and not put it through is because Dr. Burry and I realized, and she mentioned how we get a lot of angry calls from patients when we put that through their insurance, especially if we don't have any free naloxone available, because it messes with their life insurance plans, and it messes with their just insurance copays and etc. So we put it in and put it on hold. And then we're going to fill that opioid and add in an opioid emergency action plan printout to basket. And you'll see what that looks like in just a second. But these should already be printed out and put next to that workstation. So all they have to do is really grab that and put it in that basket. But okay, going back to this. So we hit that complete and hit number 6. And then this is what should pop up again. And we click that number 3, high risk naloxone. And this is what pops up. So now this is kind of the pharmacist's job. So when the pharmacist gets that opioid emergency action plan printout, they immediately realize, hey, I need to counsel this patient. And this is that opioid emergency action plan and Narcan instructions for use. Both are crucial tools to include with every naloxone fill. On the left, we have a customizable action plan that gives patients to fill out at the pharmacy. It reinforces key emergency steps like calling 911, giving naloxone, and repeating in 3 minutes if needed, and staying with the patient. This document also helps families prepare before an emergency happens. And then on the right, we have step-by-step Narcan instructions with visuals to walk patients or caregivers through how to identify overdose and properly administer that nasal spray. Both are included in our naloxone counseling, their front and back pages, to make sure that patients walk away with not just the medication, but the confidence and knowledge to use it if something happens. But this, in case this printout, they run out of that printout, we did keep it, we did keep a link for it right here in the under that tab 3, so the pharmacist could easily open this up and print it right here. But after that pharmacist counsels, they see that printout, they put it in with that prescription in the bag, and when they are picking up that prescription, the tech or whoever's checking them out should look at that piece of paper and be like, hey, this person needs to be counseled. And that is one way it can go. And then another way is, because the second 2 action plans are not completed on their end of the computer, it pops up and it doesn't really let them give out that naloxone until they finish out these care actions. So 2 ways it can alert them in that workflow process that they need to counsel. But after they do that counseling, they're going to go to this number 3. And this is just for that pharmacist, like we talked about before. And it just gives us instructions. Hey, if the patient's high risk, walk through this emergency action plan, which you already should have. And then after counseling, please highlight below whether the patient has accepted or declined naloxone after that counseling encounter. So for our purposes, the patient had accepted that naloxone. So if accepted, fill that prescription that we had put on hold for that naloxone under that standing order. And regardless of whether the patient accepted or declined, we have to complete this care action and change the status to care plan reviewed and updated. So we're going to hit that complete and hit number 3, and then it says head over to care goal sign off. So this is what pops up, and we're going to click that number 4, care goal sign off. And in this, it just says, thank you for completing this care goal. Reason why filling, not filling, please highlight. So we're going to go ahead and highlight that they filled it, and because they were at high risk. There are a couple other options. As you can see, you can fill it even at the pharmacist's discretion. So maybe they weren't high risk, but a pharmacist knows their patients best. There might be a patient that has been coming in for a long time, and the pharmacist realizes, hey, I know this person really well, and while they might not have qualified for naloxone, I still think that they need it. So that's what that's for. And then if they don't fill it, they can be low risk. There could be no change in the care plan from all the way step 1. Patient already has received naloxone from that outside source. So this you would find out during counseling, or the patient has denied counseling. And then, so those are the options for you guys. And then the date, you would date it and then sign off with your initials or your full name. And then you would change the care goal sign off to complete this care plan. But this is also very important for them to do. They have to do that provider notification form. So it's just a reminder for them. So they're going to go under a reports tab, which is going to pop up right here, and either click on naloxone dispensed provider notification or naloxone not dispensed provider notification, and fax that over to that provider. So this is what both of those naloxone dispense provider notifications or not dispense looks like. This was one of the most meaningful improvements we had made during this project, was closing that communication loop with that prescriber, a crucial piece of responsibleness in that opioid stewardship program. By implementing an automated provider notification, now it alerts prescribers both when it's dispensed and, more importantly, when it's not dispensed. The simple real-time intervention did 3 big things. It documented the pharmacy's role in real time, reinforced that prescribers' trust in our services, and transforms what used to be a passive interaction into an active, measurable harm reduction strategy. So, like I said, in that Pioneer system, under that reports tab, you should find two key forms side by side. And the first one, it notifies providers whether that naloxone was dispensed, and that was already pre-installed at our pharmacy. By Dr. Burry. And then the second, which is what we created during this rotation, flags patients who are high risk, who have denied counseling or were ineligible. This kind of triggers appropriate follow-up and reinforces safety, and kind of tells the prescriber, like, hey, help us out. We think that this patient needs that naloxone. Since Pioneer didn't really allow us to create brand new reports from scratch, we worked around it by identifying a similar built-in report template. It was a .rpx file. We duplicated it and customized it with our fields and layouts, and then re-uploaded it. That file is now fully embedded into our system. So now we don't really have to use outside platforms or bouncing between windows, because before there was a link there, and that link would open up a Google Docs and they would have to manually edit everything in. So for future users, this process is going to be pretty easy. They have to download that .rpx file that I've shared with Dr. Viracola and go into reports, manage, import it, run a test to confirm everything auto-populates. And one tip, it doesn't work on that home computer or a computer that doesn't have Pioneer RX app, or it supports system that supports Pioneer RX. It's going to appear as like an unreadable code, and yeah, so do it at a pharmacy computer that has Pioneer RX. But yeah, this enhancement made the workflow very seamless and efficient. So no wasted clicks, no extra steps. Data like the patient name, date of birth, risk score, and provider info all auto-populated, and all they had to do was just click that, it auto-populated, and click send, unlike before where they had to type it all in. So yeah, this template can now be used by any independent pharmacy across the state. So it's pretty scalable and replicable. It's a replicable solution that hopefully should make a difference as well. But anyways, going back to our patient, the one on the right for reference is what the naloxone not dispensed provider notification will look like, but we're going to be focusing on the naloxone dispensed notification for the purpose of this patient. So we're going to go ahead and click and send that over. So we're going to go ahead and let them type up when we sent that provider notification form, and hit complete, and hit that care goal sign off success, because we're done now. And that's it. That's the workflow for high risk. And then we're going to talk through workflow for intermediate risk. But does anybody have any questions for the high risk workflow? Okay. Okay. So our workflow algorithm 2 was intermediate risk, where we, this is when we're going to use the RIASWORD surveys. So again, here, this is a lot of the same thing, but that first initial RX review tab pops up. We're going to go ahead and highlight yes or no answers for these documentation purposes. For our patient, they didn't have naloxone already prescribed by the provider. So we're going to highlight 2. We're going to proceed to question 2. Has naloxone been dispensed for the patient within the last year? So they're going to go back into that past medications tab, look. For our patient, no, it wasn't dispensed. So we're going to hit that complete and change the status to 0 RX review complete. And then this is what it looks like again. So we're going to hit that number 2, the ORS RIASWORD assessment. We're going to again hit that PMP lookup and look up what their PMP score is once they log in and search that patient up. So for this patient, their score was 310 and their average MMEs per day was 3.4. So we go ahead and noted that right over here. And then we're going to go ahead and highlight the interpretation and complete the action associated with that interpretation. So the ORS interpretation and action over here, so was it 0 to 250? No. was it 251 to 449? Yep. So they're at intermediate risk. So we're going to go ahead and proceed to that step 2, RISOR tech survey, because further assessment must be completed. So when you scroll down, you see this, and we're going to go ahead and open this risk calculator and select the tab at the bottom titled RISOR Tech Surveys. When you hit that link and click that tab, this is what it should look like. This basically just has check boxes. You go back into their prior medications and you see what applies to the patient. And then the score should auto-populate. So for our patient, we clicked the oxycodone and because they had an oxycodone and they were on antidepressants. So we clicked those two, and our score we got was a 10. So that should tell us that we need to continue to that RPH RISOR calculator. So we go ahead and noted that right here. And then in step 3, it tells us if the score is 25 or greater, that's not us. Is the score is less than 25 points, that's us. So additional RISOR evaluation by RPH is needed. So we're going to go ahead and leave this action open and fill that opioid prescription and throw in the basket an orange paper labeled RPH RISOR pending, and no further actions for technicians is required. So we can go ahead and save this and leave it open, and leave it into put this status as RPH RISOR pending. So when they get that prescription, not only the workflow alerts them, but this little orange little paper attached to that prescription should alert them like, hey, I need to still go back and determine if they're at risk or not. So once they get that prescription, now this is the pharmacist's job. So now, as the pharmacist, I'm going to go ahead and open that same number 2 ORS and RISOR assessment back up, because they still haven't been determined high or low risk. So I'm going to go ahead and scroll all the way down to RISOR pharmacist evaluation. I'm going to go ahead and assess and click each box for what applies to that patient on this link. So when I click on this link, this pops up. This is the second tab for which is labeled RPH RISOR. And here I'm going to also click what applies to our patient. But for this patient, since nothing applied, our total RPH score was 0, and the composite score was 10, because composite is RPH plus tech score. So we're going to go ahead and document that right over here, as you can see. And over here, it lets us know if the score reaches 25 or greater, that's not us. If the score is still less than 25 points, we're going to go ahead and complete this care action and change that care status to low risk, do not fill naloxone, and then go to that care goal sign off. So we're going to hit that complete and hit that number 2 low risk. And really quickly, if in case at this step the score was 25 or higher, just for your information, it would kind of walk you through that same process that we did for that first workflow, which was that high risk naloxone workflow. So you would go to that tab 3, but since they aren't, we skip all the way to 4 and go to that care goal sign off. So we're gonna hit that number 4 and click care goal sign off. And here we're going to highlight where we're not filling or filling it. So for this person, it was low risk. And so we just didn't fill it. We're going to date and review. And for this patient, we don't really have to do a provider notification form because they were at low risk. And as a pharmacist, you determined, hey, we don't think that they really need naloxone. So we're going to hit that complete and we're done. So that's our care goal sign off. So now let's talk about the risk calculator. We used validated scoring tools like the ORS and RISOR to assess patients' overdose risk based on their patient profile and comorbidities. So here's how the overdose risk score, or ORS, fits in. We put the patient score from that database and enter it here. If it's under 250, they're low risk. No naloxone is needed. If it's between 251 and 449, they're intermediate, and we follow up with that RISOR. Anything above 450, we go ahead and dispense that naloxone and go through that high risk workflow. So this kind of gives us our staff a simple color-coded guide to ensure that there's consistent action based on risk level. However, this is pretty straightforward. So if they don't want to use this and they kind of remember these numbers, they might not really click on this tab. So if the patient's aura risks falls in the intermediate range, we use this Tech RISORD survey to dig in deeper. We check if they've been prescribed any high-risk medications or have a high MME or are smokers. And like we looked at before, each checkbox adds points. And if the score hits 25 or higher, we're going to go ahead and stop the assessment. And if it's below 25, we pass it on to that pharmacist like you saw before. So once that technician's RISORD score is calculated, if it's borderline or unclear, the pharmacy will do this, our pH RISORD survey. If it's 25 or higher, naloxone will be dispensed. And if it's not, we're going to go ahead and go through that low risk pathway like we looked at before. So now let's take a look at the finalized policies and procedures. This is everything we talked about put into a document. It's here for reference. It was really created for the pharmacy to have a proper guideline in place, but I'm going to go over it in the next slide so you guys have a bit more of a visual picture instead of just reading these words. So it all begins when an opioid prescription is received. The first step is checking if the prescriber sent a naloxone prescription. If yes, and it's already been dispensed in the past year, or the care plan was reviewed in the last 6 months, we're going to go ahead and stop that assessment and fill the opioid or RX as usual. But if naloxone hasn't been dispensed, or if the care plan is outdated, we initiate the initial RX review, opening the ORS and RISORD risk assessment. So the technician first checks that PDMP for the overdose risk score. If the OR, depending on what the ORS risk score is, these are the different pathways. Again, if it's below 200, stop the assessment, go to care plan sign off. Intermediate risk, do that Tech RISORD. If it's still undetermined, the pharmacist does the review, and etc. But eventually, with every step, we make sure to capture why that naloxone was either accepted or declined, and we want to notify that provider and do the counseling and sign off that care goal in Pioneer RX. So let's talk about overall findings and future work. So let's start with our screening outcomes. As shown in this graph, we screened a total of 21 patients. Out of those, 19 were classified as low risk. That's the green bar, and there are only 2 considered high risk, shown in red. This really highlights a key challenge we faced during implementation. The majority of the patient population at Carborough was at low risk, which made it harder to fully assess the impact of the service on high-risk individuals. It also limited the number of patients who qualified for naloxone through this program. Now, even amongst those few patients identified as a high risk, we faced additional barriers. The second graph shows that only 1 out of the 2 high-risk patients accepted that naloxone when it was offered. While that's a 50% acceptance rate, which might be encouraging, but it also might suggest that there might be some accessibility issues. And if I remember correctly, the factor that influenced this patient in specific was a delay in receiving that free naloxone shipment. Which meant the patient might have had to pay out of pocket, which ends up being a big deterrent for most community pharmacies because naloxone is not really covered under Medicare Part D. So one of our biggest wins that we already talked about this month, but it was embedding that provider notification form directly under that into Pioneer RX. And another major focus was refining our workflow algorithm by simplifying the language we use throughout the process. So initially, Dr. Burry and I found that the wordier workflows were taking between 5 to 10 minutes to complete after some practice. That's too long for a busy community pharmacy where every minute really counts. But we also didn't want to compromise on that clinical quality, especially when it comes to something important as counseling these patients. So we struck a balance. We worked on making that workflow more concise, cutting steps, rewording where possible, while still preserving the key counseling opportunities. And by the end, we had successfully reduced the overall workflow to, I would say, around 20% of its original length, which is a significant cut and had noticeable impact on its usability. We also took a hard look at the number of tabs, care goal statuses, and actions being used in the system. And at one point, we had over 10 care actions, and it became clear that it was really overwhelming for the staff. So we consolidated. Now, as you saw in the workflow, there's only 4 to toggle through, and only the most relevant care goal statuses remain. This makes it much more intuitive and practical for that day-to-day use. So one of the key challenges we faced was getting that pharmacy buy-in, because like many independent pharmacies, we had to find a way to incorporate it into an already busy workflow. And there were already so many things that they were doing that, selling, like making sure that someone realizes, like, hey, why is this important? I think that's really, really important to emphasize. But overall, I think that our specific pharmacy did a great job with kind of really immediately picking up and understanding, hey, this is really important, and they were really quick to pick up with learning the 4 tabs as well. So it wasn't too bad, but initially finding that those 12 tabs or 10 tabs were pretty overwhelming. Another unexpected hurdle was that the majority of the patients screened were actually at low risk. So again, it was really tough to test the service on high-risk patients, which would be that group that benefits the most. However, I would say it's still really beneficial because the patient is at, if the patient is at low risk, that process should only take like 30 to 45 seconds, and it's really quick. So yeah. And another thing is, because there were some issues in that naloxone delivery, that could also deter patients that might not want to pay out of pocket. And for pharmacies who don't have this free naloxone program at all, that could be a big point on concern. We were lucky to even have this free naloxone, to be honest, in the first place. So yeah, and then finally, there's that financial side. For independent pharmacies buying naloxone through wholesalers, the return on investment is really unclear. So especially, again, for those pharmacies who don't have that free naloxone, without that guaranteed reimbursement, that hesitation to stock that naloxone, it is understandable, not correct, but understandable. And looking ahead, we want to streamline this workflow integration. So right now, technicians have to really exit Pioneer RX and manually access PNP Aware to retrieve those ORS scores. But Pioneer has integrated it into the system for pharmacists, so we know it's possible. And based on North Carolina laws, it does allow that. So maybe we can get something specific to our state. I also really emphasize on embedding that provider notification that we developed right into that reports tab. And on the data front, we already collected these initial findings, but expanding that data over 6 months could also be beneficial for this pharmacy to see, hey, am I getting more high-risk patients? Does this really make sense for me to do this workflow? And for scalability for all pharmacies in general, it would be very nice to expand this even further. And I think this really builds a strong foundation for why we should implement it. And lastly, I think we should advocate for pharmacists to get, or pharmacies to get that reimbursement, because it reinforces our clinical and economical value of our work, essentially. But yeah, that will be all for me. I really appreciate you listening to my very long presentation and paying attention. But what questions do you guys have for me, if any?